Really excited to kick off this session first with Deepak Vora from the Department of Veterans Affairs and Duke, and talk about the VA's efforts to implement.
Good morning, everyone. Thanks to the organizers for inviting us to be here, and great to see so many friends today. So I'm going to try over the next 17 or 18 minutes, I've been told, to go through what we're doing at the VA. It's a bit of a packed agenda, but I suspect the slides will be distributed. So if you miss something, you're welcome to have these. So just to share with you a little bit about the VA, in case those of you are not familiar, we are the nation's largest integrated healthcare system. We take care of over 9 million veterans. We're also we also dispense medications as well. So over 7 million of our patients are using the VA for pharmacy services. The actual number is a little fuzzy, but it's roughly 160 healthcare systems spread out across the country, including Alaska, Hawaii, and several U.S. territories. And I put the word in single in quotes. So we are, yes, under a single EHR. I would say they're loosely integrated. So you can think of us as individual EHR instances that use the same software with maybe a little bit interconnectivity that but not the full level of interconnectivity you would hope or expect. There is ability to pull data from across all of the centers and use that in a standardized way. And of course, we are in the middle of transitioning to a different EHR, which you've probably heard about as well. So all of that is going on in the background. So we started this in 2019. We were lucky to have received a very generous donation from Sanford Health, and that allowed us to really start to build the infrastructure for preemptive panel-based pharmacogenomic testing really at scale. And so this really hadn't been attempted in the VA before. And that partnership with Sanford is still active, though slowly coming to an end. And we've learned a lot over the last 5 years, and we've really used that information to help us pivot to kind of the next phase of our journey along this adventure. First of all, pharmacogenomics, clearly a team sport. No one specialty, traditional medical specialty owns pharmacogenomics, and you really do need to pull together multiple disciplines. Can't do pharmacogenomics without pharmacists. I say that once, say it again. And so I'm a dumb cardiologist, and so I learned that really quickly. And so so we have lots of pharmacists, many VA pharmacists in the room today, so feel free to pick their brains later as well. I would say preemptive pharmacogenomic testing, though I love the concept and the theory, is not quite, we need a different model, I think, for preemptive pharmacogenomic testing. The idea that a physician is going to order this, or a healthcare provider is going to order preemptive testing as part of, just like any other lab test, I don't think that's the right model. I think we need to think about, not that we have the same level of evidence as vaccines, but I think you need to think of that kind of model where it's someone else coming in and bringing this to the patient, maybe at the entry into their healthcare system or through some other healthcare provider. I just don't think the traditional lab ordering is the right way to go for preemptive testing. Implementation science, Sony, great overview. We've really tried to infuse as many of those principles into our processes as possible. And then I think the other thing that we've learned is that funding for testing and clinical decision support, I think those are huge barriers. And but they're not the only barriers. And so even when we have solved some of those, and through this partnership with Sanford and some of the other tools we've built, there's many other barriers that we've learned that really are needed to overcome to really get to better adoption. So we've spent the last 5-6 years building this toolkit. What I think of as our end-to-end support for any VA healthcare system to be able to implement pharmacogenomics. And I could spend an hour, and many of you have probably heard me go on for an hour about all of these things, and I would love to do that, but I won't. But I'll focus in on a few areas. Obviously, access to high-grade testing is kind of the first thing that you need. And so this is our primary pharmacogenomics panel. So we do panel-based testing. We're up to, I think, 16 genes now. We have alleles that cover a wide array of the genetic ancestries of patients that we see in the VA, and that's kind of a usual listing of medications that are impacted by these panels. We do use other reference labs as well, where we have to fill in gaps geographically and for regulatory reasons, but this is kind of our primary panel. And it's evolved over the course of our time. We started with an 18 panel, and we've moved up to this current panel that we have in production right now. We outsource all of our testing, so that's part of the partnership that we have with Sanford Health. So we outsource all of our testing outside the VA, and that's allowed us to really focus more on the implementation side of things and not have to focus so much on the laboratory testing. This is kind of our current footprint. So like you said, we have about 160-ish healthcare systems across the VA. 137 of them have access to testing through our program. We've got a number that are on deck, and then there's a small number, about 20 or so, that have been somewhat resistant. And so that's the other theme, is that there's lots of variation. There's VA's it is an integrated system. There is some national governance, but it's not. Most of the decisions are made locally in terms of what to do and how to take care of their patients. And so that's another lesson. And then at 65 of these health systems, we have embedded pharmacogenomics trained clinical pharmacists. And I'll tell you more about what they do or what we would like them to be doing in the subsequent slides. We test, we've grown a lot over the last 5 years. So we test, we order roughly 6,000 patients a month. About 5 of those turn into completed orders a month. We've tested roughly 60,000-ish or maybe more since program inception. We've had roughly 8,000 unique ordering providers. And you can, in this middle plot here, showing how often providers are ordering. It's about once a week. So this is not something they're doing every day, but most providers are doing this occasionally. And so we want to obviously see that improve. In terms of the types of patients that are being tested, we skew mostly to an older patient population, as you might imagine, those that are using pharmacy services. Our race and gender breakdown is roughly on par with what you would expect from the VA. Maybe a little bit more diverse than you would expect from VA National Population Services. So at least at this level, we don't appear to be exacerbating disparities. And then in terms of the providers, 2/3 of our providers that are ordering tests are coming from primary care and mental health. And so that kind of makes sense. Primary care is where most care in the VA is given. Mental health obviously has a large body of evidence around it. It's also a large source of clinical care in the VA. But whether you're looking at the number of orders or the number of providers, roughly 2/3 are coming from primary care and mental health. Pharmacy is a growing third because of some of our latest efforts. Pharmacists are also embedded in some of the other clinical specialties, depending on how they're classified. And then the medical subspecialties are behind, though they're making a good impact still. This is in terms of equity and who's getting access to testing. This is some unpublished analysis where we've just started to analyze patient characteristics of patients who've been getting tested versus not. Older patients less likely to be tested. Minoritized populations actually more likely to be tested in the VA. So that's similar to other observations made in precision medicine within the VA that we seem, for whatever reason, whether it's the VA system or something we're doing, I don't know, we are not seem to be exacerbating disparities. Distance to the VA, so the VA sees a large number of rural patients, and so often many of those patients are getting their care through telehealth, and so distance to a VA, right now where our testing requires phlebotomy, and so distance is emerging as a barrier, and so we're looking at ways to overcome that. Comorbidities was negatively correlated with testing. I think that, so the more complex patients are not necessarily getting tested, and you can surmise why that might be the case. And then in terms of the providers that are seeing these patients, we were able to look at those characteristics. Older providers, a little less likely to test than younger providers. Female providers more likely to test. And compared to physicians, NPs, PAs, and particularly pharmacists are more likely to order for their patients. And so, so this is just a little snapshot of what we've seen so far, and this paper is under review right now, so hopefully you'll get a chance to read it when it comes out. So we'll talk more next about kind of the where the rubber hits the road, so to speak, implementation and education. You know, we started this program really with that kind of preemptive model because we had the ability to do that through this partnership with Sanford. And now we're, and in those early days, we really didn't have the ability to support and invest in clinical pharmacists just because of the nature of the funding that we had, as well as other limitations within the VA. It wasn't, we knew that we needed to do that, but we didn't have the ability to. Now starting in 2023, we're going to be investing in pharmacists, clinical pharmacists, to help with pharmacogenomics. And they're going to really, we think that they can play 3 critical roles when it comes to implementing pharmacogenomics. So there's first the actual implementation of testing in routine clinical care at either a local level or a regional level. Pharmacists are obviously clinicians, and they can help with actual clinical care when it comes to patients that are in need of testing, who have undergone testing through either consultative services or population health management approaches, and I'll show you some of that. And then pharmacists are important educators, not only to their peers, so other pharmacists that are already existing, but ultimately the providers that are prescribing medications and taking care of patients. And we're going to be switching really from a preemptive mode to now more of a reactive mode. And this is just a financial motivation here, as we are now shifting to testing that was donated to the VA to now testing that we have to pay for. Like others, we have to think about value-based care. We don't have to worry about reimbursement so much because we're a capitated healthcare system, but nevertheless, we still have to worry about bringing value-based care to our patients. So the implementation model that we're working on now for the next foreseeable future has to do with this concept of clinical workflows, this idea that there are specific patient populations that we want to target for pharmacogenomic testing that we think are high value in the short term, and that if we can do panel-based testing in these pockets of patients, there'll be more value in the short term, and then the rest of the panel will be can then be done preemptively for the rest of the veterans' care. And so we've been really, we've stood up subject matter expert work groups that are comprised of physicians and pharmacists that are taking care of patients who we think are most in need of pharmacogenomics, where we think there's sufficient clinical utility, and trying to think about, well, how would we actually put this into practice on a day-to-day basis? We have metrics associated with each of these workflows, and I'll show you some examples of those, dashboards and other tools to help providers identify which of their patients need to be tested and which patients are in need of interventions when the patients do get tested. And then we really package all of this information up into toolkits that we can then disseminate to a local pharmacist who's trained in pharmacogenomics and whose job is there to really change the behavior of providers at the ground level. And so we're doing this nationwide. And we've really tried to take, it was great to see the CFAR framework and the implementation strategies that were identified earlier. And so many of the implementation strategies that were introduced earlier are infused into each of our clinical workflows as much as possible. And so, once we develop a workflow from our SME work group, that SME work group really helps to socialize the idea not only within the VA national leadership, so getting to that outer setting, maybe not truly outer setting implementation factor, but at least at the national level at the VA, making sure that from the top down, there's an awareness of this intervention, of patients who need to be tested, and so they can help spread the word, so to speak. And then once the pathways are planned, tested, and designed, they can then be pushed out to the field. And like I said, we've been attaching metrics along the way to see how well the implementation and the uptake is going. I will say, I want to just, how do I go back here? Nope. Oh boy. Is there a back button? There we go. Yeah, so the education, when it comes to a clinical workflow, we are also investing in one-on-one targeted education with providers, and this idea that there are providers who need more attention than others, and so the ability for a clinical pharmacist to sit down with a provider perhaps that sees a lot of patients who are impacted by a particular workflow and helping them understand the clinical validity, the clinical utility, also the how-to, how do I do this, where do I go for help, and to help them kind of hold their hand, so to speak, as they go through this change in their practice, which is really new for most providers. So we've launched 2 workflows so far. So we've, as you can imagine, we've started with, as a cardiologist, we started with implementing pharmacogenomic testing in the VA cath labs. And then we've just launched two pathways in oncology, one around DPYD testing and the other around TPMT testing. And so each of our pathways has all of these elements that you see here on the side. And then obviously that's not where we're stopping. And so over the course of the next year and a half, we're going to roll out clinical pathways roughly every other month or so, and you can see all of the different areas that we want to focus on and the different specialties that we want to focus on, and so that we can really try to target our efforts into these patient populations that we think are most likely to benefit. Okay, so I think another area that we've learned is important to invest in is in this area of what we call population health management. And so to me, when I think about population health management in pharmacogenomics, this has a couple of different flavors. The first is when it comes to incidental findings. So if you're going to do panel-based testing, and as a cardiologist, I'm ordering this test for Plavix, I certainly am not looking at their SSRIs or certainly any other genes on the panel that are being impacted. Maybe I will focus on the Plavix and just take care of that, but it's unlikely I'm going to look at anything else. And pop-ups and clinical decision support tools really don't help in the setting because the test is coming after the prescriptions have been written. So you need somebody to look at that panel to see if there's something that needs to be addressed on the day that test result comes back. Now, if they've been on a statin for a decade, okay, we're not going to worry about it so much. But if they were, let's say, I'll flip it around. If a mental health provider orders this test for the SSRI and they just got a stent a month ago, that's probably someone that we should take a look at. And our CDS tools don't, in the VA, wouldn't capture that because they're all prescription-based. So there's a gap there. There's also heritable conditions. There's not many, but there are heritable conditions that come with a typical pharmacogenomics panel. This is not like BRCA testing or something like that, but there are implications for patients and their family members, and we think it's important for someone to capture that and return that result, that information back to patients and providers. And then over time, there's also the need for surveillance, so that over time, no matter what, someone will be picking up high-risk drug-gene interactions. So these are the kind of the workflows that we used for population health management. So we were trying to identify those high-risk drug-gene interactions that maybe have slipped through the cracks, so to speak, when you do a panel like this, risk stratify them, right, and then triage them. So if it's a high-risk drug-gene interaction based on rules that we've identified, that should go to a clinical pharmacist that's locally based, who can do a chart review and communicate with the local providers and decide, is there an intervention here or it's not. It may be totally appropriate for them to stay on that drug, but there might be an opportunity as well to make an intervention. There are other lower risk interactions that don't need to be taken care of today, but maybe should be taken care of at that next appointment with that prescriber. So it's building the system to identify these, triage them, and then communicating out to all the appropriate people in a timely manner. And then the heritable diseases, we are implementing heritable disease findings for G6PD and UGT1A1 right now, and we're looking at DPYD and RYR1 next. And what do we tell a patient when it comes to these findings? What do we tell that provider? Is there any follow-up that's needed with either a medical specialist or a medical geneticist? And so those are things that we need to implement at scale so that we can do this in thousands of patients every month. So this comes then back down to, to data and clinical decision support systems that really powers a lot of what we're able to do. And, I think the key feature for us is, and we've had to do this within the VA architecture, which has been challenging, is to really centralize all of the data that is available, not just from the vendors we're using today, but the vendors that have been used historically, aggregating all of that pharmacogenomic data into a single centralized database, standardizing the nomenclature and the taxonomies, making it updatable over time as CPIC comes up with a new interpretation or guideline, developing consensus rules that are, so we can start with CPIC, but there are times where we may want to, I know this is heresy, but deviate from CPIC. But that's something at least that we can do as VA clinicians, come in and say, well, for us and our patients, we want to go a different route maybe here, and then the rest will be CPIC. And then we need to then push that information out, not only to our EHR, but VA loves its dashboards. And so we have a plethora of clinical dashboards where clinicians can go for clinical decision support and that are outside the EHR. So we need to be able to push our data and all of these resources out. And so this is what our CDS looks like today. It's, for those of you that practice in the VA, this will, hopefully I'm not bringing back bad memories, but this is kind of what it's like in practicing in the VA in CPRS. It's essentially kind of DOS-based type text. There's no fancy colors, there's no bold, there's no nothing. It's text, and you've got two options, accept or cancel. But we've really worked really hard to make sure that this has gone through user testing, and that we have clinicians who have told us that, okay, this is the bare minimum what I need. We've tried to standardize this, so every time a clinician gets a med, that it's all in the same category, so they can quickly get to what they need to get to. And then our pop-ups now, we've put them into production for over 50 medications. They've gone off over 33,000 times, and because we are loosely integrated, we can pull all the data from each of these VAR instances and figure out what people are doing. So the alerts go off roughly 1 in 6 times, and so with these alerts, they've come on over the time, but that's been a roughly stable number. About 16% of the time, an alert will go off. And the middle graph here tells you what providers are doing when these alerts go off, and it's roughly 2 out of 3 times providers are acting in concordance with the alert. And so that was much higher than I expected, especially as a clinician that frequently is trying to get through drug-drug interaction alerts, right? But 2 out of 3 I thought was a really good place to start, and that's for all medicines. Obviously, there's going to be variation in here. And then we can also capture some of the reasons why. And some of these reasons are expected. Our system has a really hard time telling the difference between a refill and a new medicine. And so often, providers, if the patient's been stable and it's a refill, that's totally appropriate to override our alerts. In terms of other things we can do with these data, so we have now dashboards for our clinical pharmacists that are doing some of this triage work. So this is now, this is the ability for a pharmacist to be able to look across an entire multi-state region and pick up any high risk, what we think are high risk drug gene interactions. And then be able to then have the patient's name. So this is a patient on tramadol who's a 2D6 ultra rapid metabolizer. And so even though we have alerts for this in place, for some reason the patient ended up on this medicine, now a pharmacist can come in, get the provider's name, get to the patient's chart, see if that was appropriate or not. Maybe it was. If not, then maybe reach out to that provider and say, hey, have you considered an alternative? And they can do this at the individual health system level. They can also do it at a regional level. We could also do it at a national level. So it's all built in. And then once the task has been done, a pharmacist can click that they've reviewed this. So it doesn't show up again for the next pharmacist or the next time they're doing their review. In terms of our workflow implementation, we can gather metrics of uptake. So this is our some of the metrics from our DPYD clinical pathway. So we can drill, we have national level data, regional level data. You can drill down to the individual healthcare system. How well providers are ordering DPYD testing prior to chemotherapies. We can benchmark them against their peers or nationally. So if a clinical pharmacist wants to use that information to provide some audit and feedback to individual providers or individual oncology programs to show them where they are relative to their peers, they can do that. And then this dashboard will also allow them to drill down to individual providers for that targeted education. So if there's individual providers that are frequently showing up on a dashboard where there's opportunities for improvement, now our clinical pharmacists can deploy to that provider, either virtually or in person, and give them high quality education through written and online materials, and really try to get that change in practice that we're looking for. And then we can send our data out to other dashboards across the VA. And so this is my last slide, or next to last slide. But it's early days in our journey in terms of clinical outcomes. We've really focused on process and implementation and uptake outcomes. But we do track medications system-wide, and so this is will give you a sense, I think, of the direction that we're heading. And so this is I'll just walk you through this graph. What this graph does is that we ask on a monthly basis, how often in all of our patients that have been tested, how often are they prescribed a medicine that conflicts with what was on their genetic test result? And we track that metric every month. So the y-axis here is a percentage. It's about 1% per month. And the vertical line here is when they actually got tested for pharmacogenetic testing. So everything to the left is obviously what the providers were doing by chance. When they didn't have access to the test results or all the clinical decision support or the education that we have in place. And there's a big spike around the type of testing, not because physicians are worse at prescribing medicines. It's just that we write a lot of prescriptions at the time we do our laboratory testing. So there's more tests, more prescriptions written at that time. So if you ignore that peak, you're roughly at about 1% of the time by chance we're prescribing a medicine that conflicts with what would be on a patient's panel. But then in that now year after testing that we have follow-up on for 50,000 patients, it looks like the numbers are lower. And this is a qualitative analysis, but it looks like we're moving things in the direction that we would hope, that there's fewer drug-gene interactions that are being prescribed for new medicines for the panel that we test for. And until you do that, you're not going to get the health outcomes or the health economic outcomes that we all are in this business for. So with that, I thank you for the extra time, but I hope I've given you a flavor of what we're trying to do and trying to accomplish and overcome in the VA. Investments are needed. This is not just another getting coverage for the test, I don't think is enough. Health systems have to invest if they want to make this happen, because the system, at least today, isn't tuned for this type of intervention. And I think existing healthcare providers like pharmacists can be upskilled to really lead that change in practice that we're all hoping for. So, so with that, I want to thank you for your time and happy to take any residual questions.
One question over here.
Thanks, Dr. Vora. Josiah from St. Elizabeth Healthcare. Two questions for you. First question, how are you ensuring that your PGX pharmacists are trained and ready to kind of implement this? And specifically, what sort of ongoing continuing education, what sort of networking or implementation, sharing types of implementations have you guys done for those folks?
Yeah, great question. I guess I'm sorry I couldn't go to all of the details. So yes, In terms of educating clinical pharmacists, we're partnering with the University of Pittsburgh and their Test to Learn program. So we said we don't want to build this ourselves. Let's go to the people that are experts in this space to train not only our clinical pharmacists, but then give them the ability to take that content to train the 10,000 plus clinical pharmacists that are in the field. Because, it's a lot to expect have a full-time clinical pharmacist funded for a healthcare system. What would be better is if we could train up the cardiovascular, the primary care, the depression pharmacists, so that they are integrating pharmacogenomics into their care and supporting all of the providers that are in their team. And so, that's the way that we're trying to scale and disseminate this information is using the Test to Learn program.
Fantastic. The last question I had was, in your population health workflow, you mentioned that there's a triage process to identify high risk, medium risk, low risk, et cetera. Who's doing that triage?
Computers. Yeah, I mean, we I'm sorry, like, to be facetious about it, but we build the rules and then, right, then you're taking the drugs, taking the genes, taking the rules, putting them on a dashboard. But then ultimately it's pharmacists or pharmacy technicians that are looking at those dashboards to figure out what's relevant to their health system and their patient population. Whether they're in charge of a local health system, a regional health system, or we actually have a national service as well, because not all health systems in the VA have one of our clinical pharmacists. I hope that answered your question.
Thanks, Deepak.
Thanks.
Excellent. We'll have time for more questions at the end.